model, doctors, does he or she ever see the patient physically or it's any time? What is that model?
Yeah, very good question. So this is again, the doctors in our model actually do visit the villages once or twice a month. So right now it's more like once a month. Purpose of that is twofold. One is to kind of retrain the health assistants a little bit, connect with them overall. And number two is the patients who were non-critical but of slightly complex nature, who did not necessarily need immediate referral. They are told that on such and such day the doctor will actually come in person, come back for a visit. So it's like a catch all of the month who come and visit the doctor in person.
And the last question is, while I was talking to Dr. Verma, are you people going to be kind to start a pilot project for Health Foundation for Rural India in August? Are we still considering starting a project?
I think Nehaji is out. She's actually meeting Dr. Bhatia and Nagrendraji out right now, I believe.
Yeah.
I think they're...
We'd love to. Short answer is yes, we'd love to.
We'd love to have you started it sometime in August and see how it works and whatever support from our side we will be ready.
I'd like to take this moment to end this session. Well, if we have any other questions, we're going to have lunchtime, and we can all. And I think that's a great, outreach right there, opportunity for connection. I'd like to, keep this moving along because we have lunch coming up, and then also we have people that have time restrictions. So I'm going to bring up our next moderator, and he's going to introduce our next speaker. Actually, the reason I'm here is because of this next moderator, Ashwin. I call him the Great Connector. So, Ashwin. Thank you.
Good morning, everyone.
Good morning.
First of all, of course, it's my indeed pleasure, actually an honor to introduce Dr. V.K. Raju, actually. Dr. V.K. Raju and his wife live in Morgantown, so that shows their commitment and dedication. They drove all the way for this session today. He received his medical degree from Andhra University from India. He then traveled to the University of London, where he completed both his ophthalmology residency and fellowship. Dr. Raju is a fellow of the Royal College of Surgeons and the American College of Surgeons. He is the founder and medical director of the Eye Foundation of America and a clinical professor of ophthalmology at West Virginia. Again, Dr. Raju's accomplishments are extensive, and I will just list just few of them. He received an award from American Academy of Ophthalmology 4 times. He is a Harris Fellow and Paul Harris Fellow Scholar in 2008. He then received Dr. Nathan Davis International Excellence in Medicine Award from American Medical Association. And Medscape, which is a very respected organization here, he has been awarded the best physicians in USA. Other than that, actually, his passion and commitment towards avoidance blindness in children, which we'll explain it in detail. And most importantly, as Vishji Verma mentioned today about will make you infected by noon, right? So here I invite Dr. V.K. Raju, whose enthusiasm is truly infectious. Thank you.
Well, and great to be here, but I am going to mention on and off some statements may look a little negative, but I am not a negative person. I start the day with good morning God, or the good God morning. What are the problems yesterday in the operating room? And I'm glad to see a lot of friends here, especially Shashiji. The future of India, with all the things incredible, there are 3.5 million NGO organizations in India. 3.5 million, I'm sure some of you know, more than the primary schools. My interest is, of course, childhood vision, and I'm an ophthalmologist. You all know the difference between an ophthalmologist and optometrist.
Yes.
A lot of children do not know, but we need nothing wrong with optometry or in ophthalmology, but educating ourselves is the most important thing in either ophthalmology or abdominal pain or chest pain. My mentor in London used to say, there are 3 solutions for every problem or any problem. 3 solutions, any problem. First is education, second is education, and third is education. And it's always good to me, you know. But whenever I see something like that, it's like Gordon Mayer once said, don't be humble, you are not really that great. I think that's very Anyway, when Shishiji asked me to talk about this, I'm involved in 23 countries. Our foundation is involved because our greatest strength is collaborating with others. Initially, we had tough times taking these instruments, those are the days. Still at $8, at the end of my talk, please indulge, and I'm going to show 2 movie clips from Hindi, another one in Telugu, Hollywood, right? 2 years ago, they produced more movies than Hindi movies. Anybody knows the Telugu movies? Yeah. If we do like movie field, and how religious people do, I'm not an atheist, but I'm not deeply religious. My mother told me all the things, manasa, vacha, karmana, that is the basic of Hindu thought, and if you follow that, God and temples are all secondary matters. We all know that too. But still, if we do things like the movie field of India and religious people of India, I think we can advance the ECOL. I think probably if I ask me what are all these NGOs, organizations, ECOL maybe everybody concentrates on ECOL. After a while, probably no more than 5-10 years, there's no need to be a charity because you educate them and they will take care of themselves, they'll take care of others. Well, that's my little bit of soapbox introduction, but I'm very glad to be here. And when she asked me about that, yeah, I'm involved, but community workers, my mentor again, I've had a lot of mentors. They said, if you want to learn something, start teaching about it. So I want to teach about the community health workers, which I learned recently. A lot of these things, points, most of you know, in the communities and the social services and trained physicians, people who are lacking, skilled people, even in such an advanced country like United States, there are very rural areas. I come from one of them, West Virginia. We are bottom of United States, but people are like, I've been now 38 years in West Virginia, from London to Morgantown, about to leave to Chicago or California again. And today I think, thank you Lord for keeping me in West Virginia, because home to home. India and West Virginia have tremendous similarities. Some of the talks they mentioned, public health, West Virginia. I'm talking about in American context, not to compare with India. You must understand that part of it. In relation to rest of the United States, because some of our hospitals in West Virginia and Morgantown, especially, half of European hospitals don't look like that. But compared to rest of United States in one county, they have 15% of people who are over 20 have diabetes. In Bihar, Andhra Pradesh, I think UP too, Tamil Nadu, there are certain areas, 28 to 30% of people over certain age, younger age group, I think around 28 or 30, they have diabetes. More than half of them, they do not know that they have diabetes. So I'm talking about the worst scenario in this country. India is even worse. But ECOL or the foundation, they're all, if we can only work together ultimately, otherwise, I've been lecturing and listening to a lot of people. I always, when you are a speaker, you already told what you knew. Whereas if you listen, you always learn 2 ears and 1 mouth. Half speaking, twice listening. but you gave me the chance, I'm going to speak. Yeah, next one, please. Next one. Yeah, critical link among the community, that is the critical link. I'm sure some of you know Nani Palkiwala's book. Every leader, there are some of them top-notch leaders here. What Nani Palkiwala said in 1977 book, We the People, like Abraham Lincoln always used to give lecture and used the word we the people. 10% of us, if we can really practice, like Manasa, Vacha, Karmana, what you think, what you say, and what you do, if it is corrected. India doesn't need more than even 3 years, I sometimes feel. Well, if you think exaggeration, I'd say 5 years or 10 years. There's no country like United States in India, because which country has 530 million people below the age of 34 and are pretty smart people with a 5,000 plus years old culture? Even if some of them are illiterate, but they are not stupid. Next. This is the definition of the health workers from WHO. But the most important of all is, like even health workers do those things rightly. Yadha Raja Tadha Praja. It is the leadership ultimately puts them their ideas, what things they're doing. As somebody said many times in the previous talks, they're incredibly committed people in India in the middle grade. I think the middle level people of India, we have 2 institutions in IE hospitals. The middle grade technicians, especially the girls, how disciplined they are, what they can do is truly phenomenal. But we are not getting best out of those people, young people in the middle level range. They can do it not to everybody. We don't need all physicians. We can keep patients away from physicians by doing the primary health properly. Next. In the origin system, look at Russia in 1800 had something like that concept of community workers, but they had given much longer training. They are not doctors, and in China they did it in 1920s. India, we did it in about 1970s. Next. Always a history is so important to learn. Truman once said, there is nothing new in this world you will learn, apart from the history. If you look back, nothing new in this world which you did not learn from history. They're so important. And our roots of our culture, grandma stories and grandpa stories, those are more grandma. I think more grandmas are good things than grandpa, even in India. So the first day, but if they're overwhelmed with their workers and all that their guys are going to do wrong things and lie to that. Even doctors, for example, sometimes when you are busy, we say certain systems, we say quickly within normal limits. We write on our pages WNL, when you are very busy within normal limits. That may mean we never looked. It can happen to any of us, when you are busy, it can happen to any of us. So wherever, with doctors and they are overstretched it can happen, in our hospitals and our technicians, because though we have 2 institutions, our main work is outreach. Children, especially if you want to do to the children, to the future of the country, you have to outreach them, you go to them, they won't come because of various reasons. Next. Physicians' Western model, still, even if the media says Americans are hated, I was in Iran and Iraq too, people say, oh, why do they hate us? No, a lot of things that happen in America, everybody follows. America has still that kind of influence, a baseball cap or a chewing gum, you name a thing. So a lot of countries, a lot of people still like Americans because it is still the most wonderful country to live in when you left your home. Next. And one thing I always feel about India, if we really did not like here or anywhere, we can always go back. But a lot of people in other countries who are living in USA, they cannot go back to their countries in that way. I'm proud about India, but not the things that how we do the things. You can see that 189 countries, and the main goals are reducing child mortality rate, maternity mortality combined, that was the, and there are a lot of other objectives. For me, always the avoidable blindness in children. What do you mean by avoidable? Not avoiding. Avoidable blindness is the present scientific knowledge we have today, present technology we have, more than 60% of the blind with very little cost you can avoid. There's no other project or I can mention in medicine. World Bank once said the most cost-effective health intervention in the world is giving vision to child. Most cost-effective health intervention for very little, sometimes 5 cents, vitamin A. If you can do with the Hopkins, we did it in various countries, analysis, but the project did not go well because unless we have analyzed, published papers, we gave speeches, but still the effect is today there should not be one patient with one child without vitamin A because it costs so little, but it's the organizational difficulties and people collaboration. There's a beautiful book just 3 years ago came, it's called Real Collaboration. Jimmy Carter wrote on the front page, on the pad. Today, there is so much leadership in this world today. Jimmy Carter said, there is so much leadership today without cooperation. We can think of it and anyway, next. Childhood malnutrition, as I said, the childhood malnutrition can affect the eyes. When the first child is born, the mother is giving breast milk, they never develop vitamin A deficiency. Vitamin A is not just for the eyes, for our immune systems, fighting against infections. If you get simple measles, most of us, upper strata people, healthy children, when you get measles, they survive. It's a fever, little discomfort, may not go to school. Whereas if you are vitamin A deficient, if you get measles, it kills you. That's important, vitamin A. And Bangladesh did 95% of the eligible children, they did it. Nepal did 96%. India did 50% of the eligible children. Why? Because we have, like we sent a mission to Mars. We are such a highly developed country. We have that peculiar, for lack of better word, I said we have a little bit, arrogance. So we think we are not like Nigeria, we are not like Bangladesh. We think on that kind, we are, with Hopkins, we did that study in India, only 50% of the eligible children got vitamin A. That's why the maternal, child mortality rate is so high and things. Those are all can be done if we only work together. Next. So when they all are expected to do all these things, and if you are overburden them, health workers, it will be tough, and that will say, like doctors will say, within normal limits, we never work. Next. Yeah. And there are, United States spent last so many years, $40+ billion on AIDS in Africa, only in 16 countries. 16 countries, only AIDS. Political, whatever it is, AIDS. So a lot of malaria insectors, the vitamin A, head color foundation workers, all the other sanitation and water workers, those inspectors, all moved into AIDS because they paid much more salary, whatever, thousands of dollars. So that's how internationally that happens too. The way in which some politically motivated, sounds good, AIDS, we are preventing AIDS and all that, but it's got the negative consequences. There's another little book, whether anybody has seen that. Thinking that you are doing good but doing bad. There's a book, I don't know the title. While thinking you are doing good but doing bad, there's a book, those are all still things are happening. Next. Role of community workers are introduced in 1977, whereas in Russia they were in 1800, many years, century ago. Family welfare program, national, these are all, we all know these things basically, but how we can implement together with the cooperation. Again, Nani Palkiwala once said, one Indian is not just doctors or engineers or even any level. One Indian is highly intelligent. 2 Indians belong to one political party. 3 Indians belong to 3 political parties. 3 Indians belong to 2 political parties. And look at how many, political parties. But still, you could have political parties with mutual respect. The Sutras Apastamba, there's a book in the Library of Congress here, one of the floors, you have to wear gloves to touch that. Sutras Apastamba, written in 250 BC, mutual respect. Next. Levels of providers, various levels, and if they're all organization, if we do it right, with the right dharma, I think, there's no country can be like India after going through 130 times various parts. And I think about India, the middle workers, if they are really used, sky is the limit for India, not only for India, we can do it in other countries. Next, for the children especially. In spite of all this, we are always, some of the questions come, what is the effect of it? What is the number? Limited, these studies, unless, like, our friend from Hopkins said, some of the things, when you do something, at the end we have to say what are the truly results honestly. All the ICAMs, the concept may be a great concept, but so many people are blinded. Even today, still those happen because we did 500 cases, 800 cases today. After 1 year later, how many had problems? How many lost the sight? How much they honestly, the people never report those. People never ask such reports. That is a big problem for us. Next. Next. This is Nani Palkiwala's book on the front page. Nani Palkiwala was Indian ambassador in 1977. And incredible his work. He wrote many, probably one Indian who got honorary degrees from Princeton, MA University, maybe Nani Palkiwala is almost comparable to his writings like Abraham Lincoln. I know that's what he says, and to some extent, so many people endure so much in India rather than asking the politician, what have you done it last year? You said this thing. After 1 year, and nothing has changed. Next. And this is how Nelson Mandela, after 27 years of a brutal treatment, he came out as a man of peace. I think probably he scores even more than some of the greatest people who fought for peace in the world. Next. And Herbert Hoover said, children are the greatest resource, not the oil and gas, and they're all needed, but it is the children. And 23% of girls in the middle school are dropping out in India, according to a think tank report 3 years ago, because of feminine hygiene problems. Next. Anybody looked at this book called Peaceful Run? Jane McIntosh, one of the top archaeologists of the world, wrote about Indus Valley civilization. We had covered drainage in India. So Nani Palkiwala said, as we're getting better, there is drainage everywhere and water, things like that. And we had, no civilization had covered drainage except Indus Valley. Next. This all our work started in 1977, and we have worked with many, many groups, and a lot of our patients ask us to do somewhere else, so we are involved in quite a few African countries, for the last 23 countries. Some countries, very little is done. Some countries, Ghana, we have an active program in Ghana, like in India. Of course, India is a center. There are probably more than 25 countries, the doctors come to India, ophthalmologists for training. And the training we can provide from other countries, from India, is truly phenomenal, like in the United States. Next. Because of involvement and working with others, we have 2 institutions, and very, very, very busy institutions, but outreach program is a very, there are 2 hospitals in Andhra Pradesh and a library there. Next. How many of you here came with $8 left India? Right? No? So, yeah. Yeah.
इंसान से प्यार कर लो
Next one that is much shorter than this. Well, my Telugu speaking friends could translate to others, and what he says is achievements. When we think there is a wonderful, he just died 3-4 years ago, Sri Sri is a revolutionary poet. Said, what we achieved, we keep on thinking about, no, we can be having. Don't interrupt me when interpret what I'm saying as a negative guy. I'm an eternally positive, like Martin Luther King said, if the world is going to be destroyed tomorrow, I still plant my apple tree today. So, what he said is, achievement, how much achievement we said rather than, they put about 10% about you, think about that. That's what Nani Palkiwala said in his books. Compared to what Indus Valley civilization, Mahabharata with 100,000 stanzas could be done. The good and bad and ugly was already described. One Englishman said, there's nothing else in this world that happens that is not already described in Mahabharata. So, well, let's think about it. Let's cooperate and work together.
Yes.
God bless.
Always a pleasure. It's actually, I'm going to hold off on questions because we need to move on.
My boss, at least one quick one.
One quick.
A quick one, yeah.
We have been friends since 1977 and we used to play tennis together. Question is, it's a comment really, at this time you have done how many surgeries? How many residents are you taking from America to India and doing the free training?
Yeah, more than the millions, I mean, almost like examinations and surgeries are all, and we'll talk about it, but education is a very important part of the foundation. As Thakur Sahab, we discussed it many times. I think we can really educate well, and there are more than 650 ophthalmologists, general, other exchanges happened since 1977, and medical students, 2 of them come every year to United States from our medical school. We can always do those things rather than picking on each other. Let's not pick on each other. Thank you.
Thank you, everybody. We're doing great on time. Only 15 minutes off, but I think we can speed it up and get to lunch. I have one more speaker before our keynote speaker. I'm going to bring up Vish Verma. Actually, he came in and joined HICL roughly, 6-7 months back, but has known of HICL for a long time. And since he's come, I talk to people and action. And first, Shashiji, everybody knows everything is action oriented. So it's just do it and see what happens. And I think since Vish Verma has come, he has brought nothing but more action to the organization and just getting things done. So I bring him up, and he's going to continue the dialogue on the community health initiative, and I think it's going to become one of our key elements for today.
Thank you, Zaid. First of all, happy Father's Day to all of you. Secondly, I listened more closely to Dr. Raju's speech than you can imagine. And he got a big applause for showing movies, didn't he?
Yeah.
So I'm going to shut my mouth and show you movies.
Yeah.
Is that good enough?
Yes.
Great. So, just a couple of notes of introduction to the movie. This talk was supposed to be titled Confessions of a Businessman. What do we think of a businessman typically? Cold-hearted, hard decision maker, etc., don't we? Isn't that the stereotypical image? Well, in my mind, the image of a businessman is bottom line. So when we talk about ACL, the Sevikas, or any of these programs, as a businessman, I ask myself the bottom line, the impact. Not we did 100,000 surgeries or raised 100 or conducted 100,000 meetings or training sessions, but the impact. And the impact is in the quality of life of people, not only of India, but all of the world. Because as we, all of us know, Vasudev Kutumbakam. So, the other side of Vasudev Kutumbakam is, not only are we one family, but the diseases that affect, the problems that affect, the challenges that affect one part of the family in Asia or India also affect other parts of the world. So, my first video is to give you a sense of all of these programs that you heard about from Dr. Bhatia, from the ACL group, and many others, about trying to reach the rural, the hard-to-reach people in need. Disease is universal. Access to health care is not always so. What is this last one? Let's take a look at that. Yeah.
No, all the way to the top.
There's 1 minute.
This is where Dr. Rajesh Punjabi, right?
Yes.
I was there last night.
Should I stay or should I go? If you say that you are mine, I'll be here till the end of time. So you got to let me know. Should I stay or should I go? It's always taste, taste, taste. You're happy when I'm on my knees. One day it's white, the next is black.
Since 8 o'clock this morning, we found our way to get to Dajira and Nyongba. And it's not easy as you see in the river, it's very filled because of the rain that falling. So you see the canoe men coming there across, bringing the canoe so they feel us can get there.
Should I stay or should I go now? If I go there will be trouble. And if I stay it will be double. So come on, let me know.
Yeah, honorable. 35 minutes walk. So you have to
You don't want me saying exactly who I'm supposed to be. Don't you know?
So when Dr. Acharya describes the OR in a hut in the middle of a, by the way, your pronunciation of Sundar Bansai, that's a minority. When he describes that, to paraphrase Shakespeare, I would have said, if you have tears to shed, prepare to shed them now. That is what the world confronts. Now, when we think about places like that and places like this, and then we look at a glass of water half empty, half full, the classical thing is the optimist looking at the full part and saying the glass is half full. The pessimist saying it is half empty, the glass is empty. I am an opportunist. The opportunist picks up that half-empty glass of water and brings it up. And today, in the next movie, I'm going to show you the story of an optimist or an opportunist who picked up that half-empty glass of water and made something of it. Let's take a look at it.
Million people on the continent, half of the continent, live in so-called last mile villages where they have no access to a doctor. We created Last Mile Health, or Tiatine Health as we're known in Liberia, to solve that. We wanted to save lives in remote, hard-to-reach villages. But we had made a commitment, because the government of Liberia had asked us to go the last mile and go to Konobo. And we were going to figure out how to do this. So we had to rethink the entire way rural healthcare was done. Who had never even finished 7th grade, could she really perform medical care like I could? She may never learn surgery, but she certainly could learn the basic medical skills that have the highest impact. And if she did, she could save lives in ways like never before.
So we took Zakba, ran her through 4 tests before we deemed she was qualified to do her work. She did training not just for a few days for 1 or 2 diseases, but for 6 weeks, and not just for 1 disease, but for 10 diseases, and not just to educate, but actually to diagnose and treat. And then we gave her a backpack full of rapid malaria tests, another 1-minute test, and antibiotics, and stuffed it in a backpack, and assigned her a nurse mentor who provides her with weekly supervision to help her grow her skills continuously. Tied all that, all her performance to a paid contract, and the outcome of all of that is that you have someone that's treated not like an amateur, but just like any one of us would want to be on our jobs, treated like a professional. And because of that, she performs like a professional. She's mastered 50 medical skills. She can treat kids for pneumonia and malaria. She can attend emergency births. The list goes on and on. More support to thousands, hundreds of thousands of community health workers like Zakba around the world. We could actually save millions more lives where people say it cannot be done.
Instead of thinking about bringing villagers to hospitals to get care, we had to bring care to them. And we had to do it not with doctors, but with villagers themselves, and teach them how to provide care for their own communities. They doubled the rate of survival for women with HIV. They doubled access to malaria and pneumonia treatment for kids. And they're doing all of this in places that have never had treatment before. And unlike doctors, they're going to stick around for the long haul and make a permanent impact. Liberia to 1.5 million rural people, there's a catch. We need people like you. We can't do it alone.
How many of you have heard of Dr. Raj Punjabi? So, very few in this room. So therefore allow me just a few seconds to tell you who he is. His family moved to Liberia in, I believe, in the late 60s or early 70s. And then came the horrible civil war in Liberia. And he left Liberia with his family, I think at the age of 4 or 5 or 6. Came to the United States, settled in North Carolina, became a physician, never forgot it. So this is what he did with the opportunity, with the challenge that he was confronted. And if that doesn't move you, if that doesn't motivate you, if that doesn't fire you up, if that doesn't fill you with a sense of passion, I don't know whether this mere businessman can do anything. Bring that challenge into your heart. Thank you for it.
So next, I'd like to bring up Shashiji, and with that, she's going to introduce our keynote speaker for today, and then also close the session. So just bear with us a little bit longer, and we'll have also, after that, we'll have lunch. And
after lunch,
yeah, and please do not leave, because the most important part of the day is going to start right after lunch, which is our work. So all this talk is nothing without action.
So let me first once again thank everyone. And also let you, I should inform, when Dr. Bhatia was here to me this morning, we should have introduced Dr. Calvo because they met in Montgomery, in Anil's office. So we forgot to do that. But nevertheless, when Dr. Bhatia came here last year for the meeting, for the national meeting, he visited Maryland, and then Dr. Bhatia and Mr. Mata, we took them to meet Dr. Calvo. And that was the meeting that was initiated by Anil Srivastava. Not related to me, but I take my sort of knowledge base from him. He gives me some email, and I go home and I say, what does Anil mean by this? And it takes me a few days to really understand what he meant. So that's how resourceful he is. So Anil suggested that we should have Dr. Calvo talk to Ekal Arogya. So the best way was to talk to Dr. Calvo with Mukul Bhatia. And the idea that was generated at that time was that there should be knowing the volunteer base of Arogya, knowing the commitment that they have, it's better to now think about this in the realm of the community. What community should do to bring good health? It's not just one person who should try to be healthy. It is the role of the community. And the concept that he generated was Arogya working with Montgomery County, working with Human Health Service. So Dr. Calvo is invited here today. He is representing Human Resource and Service Administration. And Dr. Calvo, I'm not going to say too much more about it because I want to leave a lot of time for you to come here and speak about it. And please listen to, so the concept is what can we do as a group, not just individual groups but together, and how we can develop a model to train Arogya Sevikas with the help of the Montgomery County and HHS. That is the ideal goal.
I'm going to run the computer. Actually, will it reach up here? Or I can go way over there. I just don't want to be in the way of everybody. Come to think of it. If you can move it over here, good thing. Okay. Will it reach here? No. Okay, that's right. We'll go there. All right, let me, if I'm in your way, tell me and I can, do a little dance or something.
You're doing good. If you stay right there, you're fine.
I'm good there?
Yes.
Okay, so, I need to give you a disclosure first so that I don't get in trouble at all. So I'm going to speak as Ahmed Calvo. This is my personal point of view. So I am not actually today speaking on behalf of the U.S. government or the U.S. Department of Health and Human Services or the Health Resources and Services Administration, which is where I'm a medical officer, or the Department of Defense, which is where I'm tied to as well. But I will, however, help explain some of those entities and see how they might be of use to you. The question is, how could some of my experiences and some of these ideas be used by you? And I'm not here to tell you what to do, and I don't presume to know exactly what might be the best way. But I want to toss some concepts at you so that you can process this together, and hopefully this can be of help, okay? So a couple of concepts I want to get across first. The notion of going from healthcare to health. Now, that means when I talk about healthcare, I am making a real distinction from the notion of health. If we do excellent healthcare in the ICU of a hospital, or the operating room, or the ER, even though it's really important that the surgery be done correctly and the ICU care and all that, I don't think anybody in the room would say, oh, because you did excellent intensive care unit care, you don't have to worry about the hospital ward safety and excellence there, or the notion of treating people with kindness or respect, right? So it's important to do quality in the hospital bedside and not just in the ICU. In fact, I would broaden that to say it's important in the whole hospital. In fact, if we're realistic about this, it's not just important in the hospital, it's also important in the ambulatory primary care setting. So the really quirky thing about this is the data is very, very strong that even if you do excellent health care, you're barely reaching 10 to 20% of the actual population health outcomes, because 80% of the actual population health outcomes is from social determinants of health unrelated to health care. In other words, health is a much broader construct that requires that you think about other sectors, not just about health care. So this is a very difficult concept that I'm about to say for doctors. So with all respect to the doctors, you also need to be respected. Does anybody know the difference between Copernicus and Ptolemaios? The Ptolemaic mindset versus the Copernican revolution mindset. Because you guys, I believe, what you're doing is a Copernicus mindset, massive shift, that you're really thinking it through compared to whatever it was that was there before you started your work. And I want you to really understand this. The notion that the planets revolve around the Earth is a Ptolemaic mindset. And what it was that mathematically you actually could describe all the planets moving around. You had to put an ellipse upon a circle upon an ellipse. It got very complicated, and pictures of all this. But you could actually get very, very close to having a description of what you saw objectively through the telescope of where the planets were, if you were obsessed with the notion that the planets had to revolve around this Earth. If you, however, didn't mind, or at least were willing to consider the possibility that the planets revolved around the sun, and what we actually have is a solar system. The really interesting, fascinating aspect of this is if you're willing to shift gears,
the mathematics of the description of the planets actually gets very easy. They're basically going around, not actual circles, a little bit of ellipses here and there. But the notion, therefore, of going from a Ptolemaic mindset to a Copernican mindset is a massive sea change, right? Everybody with me on this? You understand what I just said?
Yeah.
Now here's a current problem in the United States. We are in the midst of a change from a doctor-centric mindset to a person-centered and population health, community-centered thinking. Now mind you, I didn't say patient-centered. I am way over a whole other discussion, because it turns out, if you couple the first two ideas I gave you, that health of the population cannot be solved just by the docs. It's impossible. It requires a much broader concept, a construct that deals with what I call the expanded team, expanded health team, expanded care team, which is to say, some of your data analytics people in the public health departments, some of your local people who have data in their Fitbits and in their little gadgets all over the place. That data source is just as relevant to the notion of health in the broader construct than whatever data you have in the electronic health record in the hospital, or Kaiser's, let's say, or the electronic medical record that is inside doctors' offices. By the way, I'm biased on this. The electronic medical record, just to get the definitions out of the way, I think historically has been billing-centric for the purpose of the medical practice, but doesn't really think about all the health broader constructs. And there's real data in a lot of places that could be of tremendous value. If you take all your analytics and couple them all together, there's much more insight that can be achieved than just looking at the piece of whatever is in the hospital records, for example. Okay? Those are the basic concepts. What I want to do is expose you to a variety of integration around some of these processes. I'll talk about the people-centered internet, but that's where I'm going with this in a second. I ran a meeting at Stanford on this. But basically, one of the key messages I want to get to. One, going from healthcare to health is critical to actually improve population health. We will not get there if we're stuck on healthcare discussion, and if we're stuck in kind of a tunnel vision with blinders on about only healthcare. Okay? And you'll never get to what you're trying to get to do in rural India if you are coming at it only from a healthcare point of view. Number two, a wicked problem requires partnerships and cannot be solved by a single organization. So what's a wicked problem? By definition, a wicked problem is a problem that can't be addressed by a single agency alone, because you don't have the budget for it, or because you don't have resources, people-wise, or more problematically, because it actually can't be solved by a single organization, a single business, a single government agency, or whatever. Therefore, by definition, it's going to require partnerships. You've got to get out of your tunnel, and this happens a lot with federal agencies, right? They're like, this is the only authority they have. But guess what? There's actually no rule that says they can't collaborate with each other. It's just that they get stuck in their mindset. But that's another part. The third point is this notion of network-centric approach to influence. A lot of people are caught up in traditional command and control power structure inside an organization or agency, when in reality, that's limiting themselves, I believe, to their current budget, the current authority, the current work. But in reality, they're therefore not getting to address some of the problems they really would like to address. And the only way you can get around that is to go to this notion of meta-leadership. And you should look that up if you want. A bunch of interesting papers written out of Harvard and a bunch of other places on meta-leadership. It's the notion of using everybody else's money and authority to do the kind of things you want to do by connecting up and having them collaborate with you. Back to collaboration, positive engagement, and strategic prioritization. But it requires opening up the dialogue, not about what can I do in my command, control, my one agency, my one business or company, but how do you get to community? How do you get to community collaboration? And that's what I think may be of real value to your group discussions, is what I would suggest. Okay, so let's get into some of the detail. This wicked problem, I've talked a little bit about already. I'm going to suggest that a community of solution as a going concern can be as disruptive, in fact more of a disruptive innovator than a traditional business or a new app or a new thing. What do I mean by that? So let me talk briefly about what I've been doing to get you some perspective, and then this will make some sense. I have been running the single largest quality improvement initiative in the country. So, who knows who Don Berwick is, by any chance? Anybody have any idea? Interesting. So, Berwick was the president of the Institute for Healthcare Improvement in Cambridge, Massachusetts. He happened to have been named by President Obama to head up CMS. Who knows what CMS is? You've heard of it? All right, so let's back up and give you a little bit of perspective. You have the White House. Who gets to be a member of the cabinet? Do you know what a secretary is? All right, so you have a Secretary of Defense, a Secretary of Health and Human Services, Secretary of State, blah, 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 right? That means a White House presidential nominee who has been Senate confirmed runs officially a U.S. government department of whatever it is, right? So that's what I mean by a secretary, okay? That means a department is a federal entity that's got a budget and a certain set of responsibilities. State Department, you know about? Department of Defense, Department of Health and Human Services. That's who I work for, actually all three of them. But inside those entities, there are agencies. Let's talk about HHS so that you get more drilled in. If I say research, which is the agency that pops in your head? Biomedical research. NIH. It came up earlier in the discussion, right? If I say epidemiologists, biosurveillance, then which agency pops in? CDC. If I say the single largest infrastructure of healthcare delivery in the country, what agency pops in your head?
Managed care.
CMS.
CMS. Actually, CMS is an insurance company, functionally.
Yeah.
Let's think this through, okay? NIH does research, but it also both intramural and extramural funding, right? So the NIH funds a large amount of the research biomedical university functions all over the country, right? Actually, globally, it reaches all over the country, right? So it's delivering health care through some of the research work, but you don't think of it as the delivery of care. It's got an NIH clinical center, yes, but its real import is the research. Medicare pays the docs, but it's the docs that are giving, the medical group and the hospitals that are giving care. And they play also Medicaid in all the states, who then gets matched by the state funding, and they deliver the Medicaid product, okay? But there's actually a funny little agency, actually it's not that little, which I need to orient you to a bit, called HRSA. The Health Resources and Services Administration is the agency I work for, and it's a very complicated agency. Give you a sample. Do you know what PEPFAR is? This is going to help you. PEPFAR stands, you should know this, right? The President's Emergency Relief Plan for AIDS relief globally, right? President Bush started this, second Bush. It's done all kinds of wonderful work all over Africa, all over the world, okay? If you ask most people who is the front face of, from the U.S. government's point of view, most people will say USAID and the State Department. But it's really HRSA that's the backroom work for all the data and analytics and all the mechanics of all this from a quality improvement, evidence-based point of view. The reason is that HRSA has a bureau. We're the ultimate of bureaucracy, though I should disclose that too. So NIH has institutes, right? 37 institutes. CDC has centers, center for this and that. HRSA has bureaus. So if the bureau, called the HIV/AIDS Bureau, runs the Ryan White HIV/AIDS program in this country. All the research around HIV/AIDS relates to that and such. It's also the back room to this whole PEPFAR stuff. Okay. Does anybody know what Maternal and Child Health Bureau is? MCHB runs the biggest maternal and child health effort in the nation. It's a block grant throughout different states in this country. It sits at HRSA. The Bureau of Health Workforce touches every single primary care, public health, nursing, social worker, community health worker program in this country. The Council for Graduate Medical Education, all the residency programs are all related to that bureau within HRSA. In fact, does anybody know the National Practitioner Data Bank? You know what that is? That's where everybody who's lost a malpractice case gets named, right? That sits in our shop at HRSA. Has anybody heard of the Office of the Advancement of Telehealth? Single largest source of money for telehealth research sits at HRSA. Homeless grants. And then one little bureau that you guys might not have heard about, called the Bureau of Primary Health Care. Okay? Which I'll fill in a bit more. Does anybody know what a federally qualified health center is? All right, so I got to orient you to a bunch of stuff. Okay, let me back up. A community of solutions, the notion of connecting up stuff with the community has real strategic value because it's owned by the community. And all of these bureaus, and all the research that has done pilots and demonstrations, there's a catch-22 with all this stuff. And that is that if you have a contract with the government, if you have an award, a grant, or a cooperative agreement, what a lot of people don't realize when they think about applying for a pilot project is that the product of that pilot project becomes government property. Think about that for a second. So, if you go to the notion of scale-up, massive scale-up on the grants level, what do you think happens with a little pilot that works? You've got evidence for it, good analytics, maybe IT connectivity and all that. Now let's take that to a massive scale-up. What pops into your head? A lot of people's worry that it pops into Big Brother because it's government-owned. That does not happen if you start at the community and it's a going concern and the community owns it. Because then it's owned by the community. Its direction is set by the community. Any navigational decisions going forward are made by the community. So that's what a community of practice or a community of solutions is in my jargon. As a Fed, I am not allowed to accept voluntary dollars, donations, or voluntary effort into something that we're doing in the federal government, because by definition, that is called an augmentation of the federal budget, and I would get in lots of trouble. It's actually one of the biggest no-nos as a Fed. This budgetary authority sits with Congress. However, interestingly enough, if it's a going concern in the community, i.e. it already exists as a community activity, I'm allowed to help it. We're allowed to give money to aid a community going from point A to point B on anything that they're doing, whether it's medical health care, whether it's evolving an IT product, but it's got to be a going concern already. So I want you to really think about this a bit, because the beauty of what you guys are doing is you never ask the U.S. government for permission on whether or not to do what you're doing. You never ask the Indian government about whether or not. So you have a going concern. You have very legitimate ownership as a foundation about the possibility of going big time with this. And that's a community of solution. Okay? The better leadership stuff I'm going to talk more about later if you guys want, but I want to get to the next discussion. So I want you to process for a second the notion of an aspirational mindset. An aspirational mindset goes like this. If I was to be able to say, I woke up and I could answer the question, I am or we are, whatever. You fill in the blank, ... That is to say, it could be spiritual, it could be community organizing, it could be just the fire in the belly belly that you have as an individual. You wake up in the morning and it's something that really passionately excites you. And it might be different for each of you, okay? But if you could then take this aspiration and affect your behavior that day, if you choose to have your behavior during the rest of the day, that is to say, what you say, do, think, or feel, be guided by that aspirational mindset, you could be doing some really interesting things. You could really be very positive, as the doctor was talked about earlier. And you could go in with this model, say A, B, C. That is to say, you're going to go down and affect your circumstances when you go to work or when you go to deal with some other activity in the community or in the world. And of course, you would factor in some corrective feedback and some other. And the point is, if you do this, you get positive feedback and really exciting value added to your sense of aspiration. Because remember, it's something that really was important to you, and no one put in your head. You thought of it yourself as an aspiration. Okay? Unfortunately, what happens a lot of times is the following. You go in and then boom, something throws you back. In other words, there's a crisis. The other C, there's budget fights or some sort of lack of authority or something happened at work, right? So what happens is most people are actually in this other C, and the circumstances are driving your behavior. You're feeling overwhelmed and stressed out, helpless, and then you end up in this exhaust cloud. In fact, you don't even realize it's a smog cloud that you're sort of fading into. People wake up in the middle of the smog and they never realize how the smog got to them in the first place, right? It's like all of a sudden it just happened to be there. But that's not possibly true. I mean, it has to have slowly, in fact, become a full-blown exhaust cloud. It didn't happen magically all at once. It was slowly building up. Over and over, we find that people have not been paying attention and they've fallen onto this side of the whole set of personal experiences or work-related experiences and are very negative about stuff. So I want you just to think about for a second, what is that aspirational, personal thing that drives you or excites you? Or certain groups have this aspirational mindset, allows them to actually go and try to do something in the world. But be careful that you don't end up complaining and blaming and just, it's amazing how fast this happens. It's very slippery, slow. Now why this is important is I'd like you to process some of what I'm going to say going forward from an aspirational group mindset. Because you guys are here for some reason. Whatever got you up this morning, each of you might be a little different, but you have a treasure in the room, which is the conversation of the whole here of everybody who's shown up. That's actually roped in, right? You're good at this, by the way. So thank you. All right, so let's go forward. I'm going to retitle the conference for a second to presentation for a second, just so they can process a couple technology things. Otherwise, you won't understand what I'm talking about. So I'm a doctor. I'm an MPH. But what a lot of people don't know about me is that I was a computer geek way before all this. So I got my first grant when I was in high school and was assigned to a hospital at Cedars-Lebanon Hospital, what became Cedars-Sinai in LA, because I had the patience to play with these computers. And back then you had to process and take all these cards in the big mainframes and go to do the syntax error corrections before you could actually get the program to choose one. Right? Some of you in the room might know about this stuff. I can tell because you guys are. Yeah. So I came into healthcare from a computer science math point of view. And so I need to tell you a little bit about a couple of jargon pieces. ICT stands for Information Communications Technologies. There's a thing called digital dividends for all that you should at some point look at. This is a State Department and WHO and UN effort to get to digital for the planet, because there's a technology gap, as you probably well know, throughout the country. And then lastly on the slide to disclose that I'm also attached to Stanford and So I teach in the Stanford Washington program. I have a long history with all of this. Okay, so why that's important is because I need to tell you about Doug Engelbart. All right. Does anybody know who Vince Cerf is by any chance? All right, so I'm trying to upgrade a lot of orientation. It's a hard, quick hill to climb. So the easiest way to explain this, there was a point in time, it's hard to remember this or imagine this even, there was a point in time in which there was no internet. Your kids may not believe this, but this is true, okay? The very, very first message, not the full message, but a little piece of the message that got through from what I'm going to call node 1 to node 2 was Vince Cerf was node 1 down in Southern California, UCLA ran stuff, to Doug Engelbart at Stanford Research Institute, Stanford S. Engelbart.